Okay, we may to continue. Also, this morning we have time for us for share discuss about the finding, and that's the first picture for you who want to try. Maybe there is Claudia. Claudia, good morning. How are you?
Massimiliano, I'm going to open the mic and the camera to the attendees.
Okay, thank you, Alessia.
Okay, Claudia wrote in the chat morning. Okay, I would like just to remember that you have to accept the invitation to interact live in order to have the icon to open your mic and your camera and interact in this session. Perfect. Now they are doing, so who want to attend is welcome, and who want to interact is welcome, opening the mic.
So guys, don't be shy. Who want to try? For example, Claudia. How are you, Claudia? Nothing. Fabio, how are you?
Bene. All good, sorry. I was trying to be silent as the kid is still asleep, but let's go ahead.
No, Fabio, I don't listen very well your voice.
Okay, I'll try to speak a bit louder.
Yeah, thank you.
Okay,
yeah, better. That's better.
Okay, so
okay, that's a I think it's not difficult to recognize this lesion. What do you think?
Okay. I don't agree. But, so I think it's definitely something that's been dissected, so it's open.
Yeah.
I'm not sure because it looks like on the bottom right, it looks like there is a vessel that's been open.
Sure. The point of view is dorsal, of course.
Yeah, yeah. So
we are looking inside. We are looking inside the vessel, right? That's correct.
Okay. Just I don't know. There is like in the middle of the in the middle of the picture, there is a kind of obstruction, or kind of narrowing. Yeah.
Yeah.
So that
that's
seems
correct.
to be like.
But I'm sorry, Fabio, did you recognize the vessel?
Well, I guess
because look.
Oh, could be the pulmonary artery because there is.
Oh, perfect. That's the pulmonary artery because, of course, that's the pulmonary trunk, and that's the branch. That's the left branch, and that's the right branch.
Okay.
If you see carefully, here there is part of the right ventricle, of course, of the infundibulum.
Okay. So, yeah, what I can see is a dissected pulmonary artery with the two branches. There is very mild irregularity on the endothelial surface, maybe, but doesn't look too bad. Maybe,
but it's not the focus.
Yeah, and then there is this annulus, which I think is the pulmonary valve annulus, which seems to be quite narrow, so hypoplastic potentially. And it looks like I can see the black dot is probably just the orifice.
Yeah.
So it's a very small one.
Yeah.
So I will call it pulmonic stenosis.
Pulmonary stenosis, yes, yes, of course. Which type?
Well, I guess it looks narrow to me, so a type B, the anaplastic one.
Yeah. Okay, and it could be a single malformation, but it could be also part of a more complex malformation. What do you think?
Okay.
Pulmonary stenosis, I mean. Which is your comment?
I don't have any comments.
Sure, but sure. Think about the pulmonary stenosis. When you are studying in a dog, pulmonary stenosis, maybe you think also, maybe there is not only pulmonary stenosis in this heart. Maybe there are other malformations.
I don't know, what is a particular breed or?
No, but a breed maybe, I don't know, breed in particular, I don't know, but there is a complex group of.
Okay, so it could be a tetralogy of Fallot.
Fallot. Do you remember which the other malformation of tetralogy of Fallot?
Yeah, it should be pulmonic stenosis, VSD,
Sure. Yeah.
Retroposition of the aorta, and right ventricle hypertrophy.
Sure. And right ventricle hypertrophy is not, of course, a malformation. Yeah. Sometimes, but it's very rare, we see also a pentalogy of Fallot. Pentalogy of Fallot is when we see also PDA or interaxial septal defect. That's the name is pentalogy of Fallot. We describe in a tiger, but also in a foal, maybe also in a dog. I don't remember, but it's very rare. Okay, other question? Okay. I think it's a Jonathan, but I'm sorry, I don't listen.
It was Fabio.
Fabio.
No, I think it's Jonathan.
The cat, but I never published it.
I'm sorry, Jonathan, but I can't listen to you.
It doesn't work. I don't know what's going on. Yesterday I struggled as well, and I always connected.
He's better now, John.
Okay. Now it's better, John. Okay.
I was saying I saw a pentalogy in a cat, but I never published it, and I just wanted to get back to the
So I understood that. I'm sorry, Jonathan. I understood that you have a case of pentalogy in Fallot in cat. Is it correct? I understand.
Yes.
Oh, it's a good case. You made to try to publish, but because it's a rare pentalogy of Fallot. But which is the last malformation? PDA or atrial septal defect? Which one?
Atrial septal defect.
Okay, good. I think it's a good case. Other question about this kind of malformation? Thank you, Fabio.
The nature of the stenosis, would you say something like infundibular stenosis if it's a tetralogy of Fallot?
Yeah, usually in tetralogy of Fallot, the pulmonary stenosis is subvalvular or infundibular. It's correct. In my experience, also in tetralogy of Fallot, we see this kind of pulmonary stenosis in infundibular or also muscular stenosis, but subvalvular. Jonathan, did you listen?
Yes.
Other question? Everything is clear? Okay, another one. Who want to try? I don't know if there is Ursula, for example, Maria, Joao. Who want?
Hi, Maximiliano. I'm here.
Ciao,
Ursula.
Ursula, how are you?
I'm okay. I'm sorry I couldn't attend yesterday, the
Don't
whole
worry.
afternoon session. The clinic was very busy. I was just able to follow the first 2 hours, and then I left.
Yeah,
It is very
I can
pity for
imagine.
me. And
Don't worry.
I'm not prepared at all because I didn't have any repetition. And but I can try.
Yeah, sure.
But
Okay, at the first, Ursula, at the first, try to understand the position.
Yeah, I think we are watching the heart from dorsal.
Sure.
And then like the atrium open, I would say probably it is the left atrium because this hole in the middle of the image is probably mitral valve annulus. Yeah.
No,
No,
it's not the left.
It's the right.
It's the right.
Okay.
It's the right, and that's of course dorsal position, of course, but also from cranial. Look at the shape of the orbital.
Cranial dorsal.
Cranial dorsal.
Well,
cranial dorsal.
I just of leaflets.
Yeah.
And I thought it's mitral valve, but yeah. Okay, that means that it's the right atrium, that it's open. On the right side, we can see the appendage on the right atrium. It looks subjectively for me quite enlarged. And in the middle part of the image, just on the top of the tricuspid valve, we can see another hole. It looks like atrial septal defect.
Sure.
I would say probably it's secundum type.
Why secundum type?
Well, it looks like more or less in the middle of the septum, not very, but yeah, actually.
Yeah. So in general, but because in general is dorsal. It's dorsal, the type secundum, because the type primum is very ventral, but usually is part of atrioventricular septal defect. Type.
Yeah, the AV canal is very, very ventral.
Yeah. In this case, we say type secundum.
Mm-hmm.
And it's the most common.
Yeah, in dogs, and that's probably a dog's heart.
Maybe it's not so clear, but here there is the ending of the caudal vena cava. Here more or less there is.
I have to say, when the heart is so cut or opened, I struggled really to find out what is the right position, what is,
Yeah, sometimes.
I'm a little bit disorientated, but.
Yeah. Sometimes it's not easy. But we are looking also yesterday, but I think it's also clear for you that this kind of experience have some limit. Of course, sometimes it's very clear to understand in the picture. Other time is more difficult. But I mean that's the situation. Other question?
I'm just wondering, is this just problem or just depending on the fixation of the heart, but on the right side of atrial septum defect, now between this defect and the appendage, this it is like more brown or dark red. Is this like just the color? It's different from other part of the wall.
Yeah, that's correct. That's because in this brownish area, there is a autolytic reaction, that's post-mortem.
Okay.
Because there is hemoglobin inhibition of the endocardium. Because it's important to remove very fastly the blood inside the heart, but sometimes it's not possible. And so yes.
Could you give me one tip how to recognize that this is the right atrium, not the left? I know for you it's probably more than clear, but
yeah,
I was looking at the valve, AV valve, and I thought, oh, it looks like mitral because I can't see more leaflets.
Okay.
If I could say the septal leaflets, then a special shape of the septal leaflets of the tricuspid valve, that it's more or less clear. But
yeah, but look also the direction of the auricle.
Mm-hmm.
Did you recognize here there is the auricle, and that's the atrium. Look at the direction of the auricle.
Yeah, then you have to first recognize where is cranial and caudal.
Sure. That's the first, because yesterday I showed to you the topographic orientation of the heart.
I have to repeat it. I'm sorry.
Which is the left ventricular margin, and it's caudal, which is the right ventricular margin, that's cranial, left to right, dorsal, apex, and such and such. That's the first. It's very important because sometimes also for you that look in the echocardio, maybe sometimes when you have the heart inside in front of you, maybe it's not so clear.
Yeah, but it's easier for me when the heart is intact, it's not open. It is
sure.
that. But that's my personal problem. I don't want to steal the time. Sorry.
No, Ursula, it's the time also for you, don't worry. But if you take care about the position and the orientation of the auricle, and I think it's clear that that's the auricle.
That is clear, yes, of course. It was clear for me, and I recognize the
auricle. Which is the orientation of the right auricle? From cranial to the right.
From cranial to the right, and a little bit caudal, maybe, if it's.
And I think it's clear that I'm looking the heart or from caudal margin or from cranial margin, because in front of me there is a septum.
Mm-hmm.
Do you follow me?
Yeah,
And so if that's the septum, that's the auricle, the orientation is from my right side. And so I'm looking from the cranial point of view.
Okay, that's you're right.
But it's clear now.
Yeah, it's clear. Yeah, I didn't think like that from the beginning. Sorry. That's
nothing. Don't worry. Other question?
Sorry, Massimiliano.
Yes.
Go, Fabio.
Fabio.
Okay. I want to ask you just a quick question. Can we use, because I had some difficulty as Ursula. I was trying to find out, and I thought it was the right side, but I was not completely sure. So I was struggling as well. Can I double check something with you? Can we use, in the mitral valve, usually we can see the posterior ring. Does the tricuspid valve also has the posterior ring as well?
Of course, it's not posterior in this case because it's parietal leaflet.
Yeah. So but can we use? So there's my question is that if the tricuspid valve also has a ring, and is the ring also a C-shaped ring?
Sure, this one.
Okay, thank you. Because the mitral valve is more like a C, isn't it?
Sure.
It's also a ring, right?
That's correct. In the mitral valve, there is not a real ring because there is a C. Because as I showed to you yesterday, the anterior leaflet have not a ring. it's free. It's free. It's only put in the wall because the fibrous triangle.
Yeah.
That's a very particular anatomical structure.
Yeah. Thank you.
Okay. Yeah, you're welcome. Other question? Okay.
I had the same question as well.
Fabio, did you need them?
No, I just wanted to clarify one thing, but Joao did it. Thanks, Joao.
Okay. Who want to try? It was a dog. Is there Claudia? Is there Mattia?
Yeah, Mattia is here. I can give it a go.
Hi, Mattia.
Hello,
How are you? Good morning.
Very good. How are you?
Thank you. Everything is clear. It's fine.
Okay,
What do you think about
it? So,
what do you think about this picture, this case?
it's a very nice heart, first of all.
I agree with you. I love this picture. I love this heart.
So, I think we've got a sagittal cut that shows both right and that must be, yes, left and right ventricle. The main chamber that we see, I believe, is the left ventricle. I hope, although there are those trabeculae. Oh my God.
Yeah, that's the left ventricle, and of course the longitudinal cut section is in this valve.
Yes, on the mitral valve area. Let's say.
and also here.
And I see the outflow tract and the aortic valve and the aortic root.
Yeah, of course there is also the left ventricle.
And on the right, I think that's the right ventricle.
That's it. That's correct. But in particular, we want to see all the left.
Yeah. So the left ventricle subjectively looks dilated to me. It does. Maybe the apex is also slightly thinned. At the apical portion, there's a thinning of the myocardium. But certainly that area, in particular over there, on the apex. But then, generally speaking, the chamber looks dilated and has lost the normal shape, like bullet shape, let's say. The left atrium, difficult to, let's say, appreciate if it's or not dilated. I believe it looks rather normal, like compared to the ventricle, though I don't know, maybe this is a chihuahua, I don't know, maybe it's much.
Because I'm sorry, Mattia, the fixation it was not so perfect because the colleague put the heart in a small box, and so there was a compression of the atrium.
Yeah. But maybe if I have to comment, I think maybe the wall of the atrium doesn't look excessively thin. Or at least from that cut. So maybe the left atrium was overall normal in size, or at least not excessively stretched.
Yeah.
Then I've got, sorry.
Yeah. In this picture is like you're saying, sure.
Okay. Then I've got a outflow tract that is visible, and the outflow tract now. I don't know. Obviously, the left ventricle is very, very large. So there's a difference in ratios between chamber size and vessel size. Initially, I saw this picture. I thought that the outflow, the aortic origin was a bit narrower than what it should be. So there was a kind of a smaller portion of a smaller aorta, let's say. Though maybe this is just because the left atrium is very enlarged and it looks like that. I cannot see any subvalvular ridge as far as I can see. I can see a normal left outflow tract in that region, and I cannot see any any dilation after that region in the aorta, so it's maybe less likely to be a stenotic lesion. Therefore, I would probably stay with the fact that that's a relatively normal aorta. And that here the right ventricle also, I think, is dilated, not to the extent of the left, but is dilated as well. And then I would probably call these as a left and right ventricular dilation. That is, I don't know, so it could be secondary to a cardiomyopathy, a myocarditis, or
okay, that's perfect. But which is for you the name of this abnormality?
You mean the name of which abnormality? The whole heart. What's the disease?
Yeah, but in particular for the left side, because for the right side we don't see it a lot. But I agree with you. Also, the right side is dilated. But in general, we may say that in this heart the problem was.
Yeah, I think it's likely to be a dilated cardiomyopathy phenotype.
Yeah. That's a DCM at the gross examination.
Okay. I thought I couldn't call it unless, let's say, I.
Yeah, and I agree with you. There are not abnormality in the outflow tract, but also there are not abnormality in the mitral valve. So what we are looking in this picture. So there are not evidence for the valvular disease.
Yeah.
And so if we do the histological examination, what we need to find from the myocardium? From the myocardium.
Yes.
Maybe we think multiple section of the septum of the wall, papillary muscle, everything. We cut, we stain, we look at the microscope. What do we make to see?
I think there would be rarefaction of the myocardiocyte with the possible infiltration of adipocytes, I think.
Yeah, maybe, okay. We made to find histological finding of primary dilated cardiomyopathy, and that's a possibility. And I will show you some picture, and maybe about myocarditis.
Yeah, lymphoplasmacytic infiltration, I guess, or actually.
Yeah, non-purulent, chronic in this case, chronic, eventually, myocarditis, maybe with fibrosis and such. Okay, and other possibility?
Well, I mean, it could be diet related, although to be less likely to this extent, maybe.
Yeah, maybe some kind of degeneration, but the most frequent are dilated cardiomyopathy with this array of fibrofatty histological type, and chronic non-purulent myocarditis. Eventually degeneration. That's a very interesting question, the myocardial degeneration, because it could be also secondary to a systemic problem.
Yes.
Yeah, there are also some endocrinological disorder. Maybe pheochromocytoma can induce with adrenaline, some kind of degeneration of the myocardium. Why not?
Yeah.
But anyway, that's the range. I agree with you. Any question?
I've got one. You see the parietal mitral leaflet? It has got some red staining on the surface. Is that just a post staining, or because otherwise it doesn't look thick or anything else? So I was just wondering if that was just a result of some hemoglobin staining of the valve.
Yeah, that's post-mortem. Look here, also here.
Perfect.
So post-mortem discoloration. In this case, also in hemoglobin inhibition of the wall, also here.
Yeah. And another thing is that at the very bottom of the interventricular septum, obviously there are all those fissures and kind of holes, let's say, in the myocardium at the apical part of the septum.
Yeah.
So those are just lower, where there are all the fissures and holes. Yeah. So those are just like processing, let's say, things that they happen, I guess.
I don't understand.
Are those those ones that you are highlighting with the pointer? Are those just processing, let's say, alterations? Like when you stain them in formalin, or I don't know, when you fix them in formalin.
But you think about the shape of this part of the septum?
No, the actual. It looks like there are holes and the fissures, like lines and holes. No, like just where you've got. Yeah.
No, that's because the fixation is not so good. And so when I cut the heart, there was some kind of piece that removed from knife.
Perfect.
So that's because of the conservation. Of course, that's sometimes it's a problem, because maybe we have a very nice finding, but there are post-mortem alteration, or the fixation is not so good. That's a limit.
Perfect. No, I just wanted to know if it was something related to that.
Yeah. Other question?
Well,
another one?
Another DCM.
DCM, I don't think. Who want to try?
I can give a go. It's John. I think my connection is a bit better, so hopefully you're gonna hear me.
Sure.
So we've got a transversal section of a cat's heart at the level of the papillary muscle. So transpapillar view, with the right ventricle that is on the left side of the image, and obviously the left side, the left heart on the right. So there is a complete obliteration of the left ventricular cavity, with a very prominent papillary muscle, so with severe papillary muscle hypertrophy on top of, I think, diffuse left ventricular hypertrophy, so the septum as well as the left free wall. And I would say that possibly the right side is slightly subjectively hypertrophied as well, but this is very subjective. Otherwise, we can see some pinpoint reddish alteration within the myocardium, in the periphery as well. So this could be maybe the cut of the coronaries. So I think it's probably not very normal. I think it's probably normal, sorry. Otherwise, the myocardium looks homogeneous. I cannot, there is maybe some alteration of fixation, but I don't think this is pathological otherwise.
That's correct. Also, okay, differential diagnosis.
So my differential diagnosis would be primary HCM or...
I'm sorry, Jonathan. I'm sorry. One question for you. What about this kind of hypertrophy? You say it's a homogeneous?
Diffuse.
Yeah, that's correct. But we may also to use other definition. Do you remember? For example, symmetric or asymmetric.
Okay, yeah, well, symmetrical then.
Yeah, because more or less there is the same hypertrophy for the septum and the wall, but maybe much more on the septum, maybe.
Yeah, so my differential would be primary HM versus secondary HM due to systemic hypertension, hyperthyroidism, and myocarditis. Infiltrative disease cannot be ruled out.
Yeah, myocarditis is not in my differential diagnosis. Myocarditis. Because usually you don't induce so severe hypertrophy. So, Jonathan, do you have real experience about hypertrophy of the left ventricle in cat? I mean, because, for example, hyperthyroidism, do you have experience about hyperthyroidism in cat with hypertrophy of the left ventricle?
Yeah, we see quite a lot, and we tend to recheck them after the I131 therapy, and the hypertrophy regresses as well. So there is reverse remodeling after treatment most of the time, but it's never as severe like when you've got like 9 millimeter thickness. Is usually kind of borderline hypertrophy around like 6-ish millimeter. So it's a moderate hypertrophy most of the time, I would say. So compare when you've got a primary HCM with a very thick myocardium. I think it's more likely something primary when you've got this clear cut. But yeah,
I agree.
That's my experience anyway.
That's also my experience. I've not many cases, many experience about the secondary cardiomyopathy because of the hyperthyroidism, but I agree with you. So, Jonathan, what about also, which is your comment about the right ventricle in this case?
I sense that there was a moderate hypertrophy as well. So we know that HCM can also involve the right side. So in some cases.
Yeah, but why? Why? Because there is a paper. I remember a paper with a retrospective investigation, but there was an echocardiography investigation, and they saw also hypertrophy of the right ventricle.
Yes, that's the paper I had in my head.
Yeah. Okay. And but there is a loose observation in this case. And it's the lung.
I think
because we are not a lot of enough experience, but also information for the lung in case of hypertrophic cardiomyopathy, also from a histological point of view. It could be secondary. Yeah. It could be secondary. Of course, I think it's a secondary, right? The hypertrophy of the right ventricle, and maybe because there is some vascular remodeling of the lung.
Yeah, or respiratory disease. Yeah, it's not necessarily a primary disease, absolutely, but yeah, we would need histology to confirm the myocardial disarray, which is probably would extend to the right, like in the left. But without histology, it's difficult to confirm.
I never seen disarray in the right ventricle. Also in this case of HEM in cat. So take care, because disarray don't care here. That's normal. Here is normal. In the junction between the septum and the wall. That's normal here. So we need to check in many slides here. Okay? Yeah. And in particular, if we cut transversally the heart, look here, for example, we have a more longitudinal pattern of the wall. And so this array is visible when I see the longitudinal orientation of the fiber. Is it clear?
Yes, it's clear. Thank you. Thank you very much.
Massimiliano, just one thing.
Eccoci, Fabio.
When we assess a gross heart, is it correct, is it technically correct to say hypertrophy, or do we need to say thickening on the gross examination?
I think in this case, Fabio, it's the case to say hypertrophy.
Okay, so it's fine, it's correct, isn't
Yeah,
it?
yeah.
No.
From a semantic point of view, it's correct to say hypertrophy. When we look at yesterday the the heart with cardiac lymphoma, do you remember?
Okay, yeah.
In this case, we have to say thickening.
Yeah, okay.
Or pseudohypertrophy in case of lymphoma.
I understand. Thank you.
Hey. Okay, just for to joke, just for to change something. The same dog who want to try, take time, study the picture.
Massimiliano, just to inform you that it's a pity, but Claudia has some problem with mic as Fabio yesterday, so I will solve during the lunch, or we are trying to do.
Yeah, thank you, Alessia.
Hi, Massimiliano. I can have a go. It's João.
Sure.
Good morning.
Good morning, João.
Hi.
How are you?
Good morning.
How are you? Good morning.
I'm fine. I hope you are doing well as well. So we have three sections. On the right, my understanding is that we have a cross-section of the trachea. In the middle, or it could be a trachea, or it could be a bronchi as well. I'm not sure, but it looks to me that it is a trachea. Is a trachea. And in the middle, we have a longitudinal section of a kidney, and on the left, I'm not 100% sure, to be honest, what it is.
Heart, of course, João.
Okay. This is a section of.
Is the lateral side of the heart? Is that the only thing that?
Okay, João, look here. Look here.
Oh, okay. Is it? I'm assuming is the atrioventricular junction.
That's correct. That's the.
And that's I'm assuming it would be the epicardium.
No, here epicardium it's
or
no epicardium. It's here epicardium.
Okay.
Okay. Follow the line. Follow the line. Which part is? Look at the laser point.
So that would be the pericardium then.
No, it's not pericardium. Look better.
Let me just increase this.
No, if it's the atrioventricular junction,
yeah.
Why there is epicardium? But of course, in this
I'm just trying to find out what is internal and is that a leaflet? No.
Sure. Which one?
I'll probably say that would be the tricuspid one.
Yeah.
There.
Tricuspid. Which one? Which one of the tricuspid?
Septal leaflet.
Septal. Perfect. That's the good first step. That's the septal leaflet of the tricuspid valve. So that's the endocardium of the right ventricle.
Yeah. Initially, I thought it was other way around. I thought that area there was the external side, and then another side will be the internal. So that is the tricuspid septal leaflet because it's directly attached to the septum.
That's correct. Sorry, Joao. That's the endocardial layer. We are in the atrium here. That's the endocardial atrium, and that's the epicardium of the right atrium. Okay.
Okay.
But if it's the interventricular septum,
yeah.
Here we are on the right, and then here we are
on the left as well.
On the left. Yeah. Follow the line.
So starting with that picture, we have a longitudinal section then with an atrioventricular junction, with the right side being on the on the left, and the left side being on the right. We can see that the interventricular septum is thickened or hypertrophic, and I can also see that on the internal surface of the left atrium, I have a discoloration, brownish discoloration.
I'm sorry, Joao. Everything it's okay, but try to recognize the anatomical structure. Okay, that's the tricuspid valve. That's the interventricular septum. That's the left side. Which is this anatomical element structure?
I thought this was I thought that this was the interatrial septum.
No, it's not the inter, because it is not the interatrial septum, because that's the wall of the right atrium.
Okay, so.
And if here we are on the right ventricle, that's correct?
Yeah.
Here we are in the left ventricle.
Okay, so if I don't, probably that would mean that all the structure that is adherent to the interatrial septum, which I thought was the interatrial septum, if it's not, then I would think that structure could be a thrombus if it's adherent to the wall.
Okay, just a moment. Which is this structure?
I cannot recognize this structure, so I thought this structure was that was adherent to the interatrial septum. I thought there was a thrombus attached to the interatrial septum from the left side. But maybe I'm wrong. Maybe I'm not recognizing.
Yeah, but no, you know. I'm sure you know. Follow me. Which is the other anatomical structure after the interventricular septum on the left side?
To me, it would be the interatrial septum after the interventricular septum. So it would be the valve. We would have the valve, the mitral valve.
But if you follow the blood, follow the blood after the interventricular septum, which structure do you
okay.
know?
Okay, I think I know what you mean. So it would be the left ventricular outflow tract.
Sure. And
okay, so that area there would be.
Look at the wall.
Okay.
Look at the wall.
I wouldn't recognize as the aorta. Yes. Okay.
Okay. Perfect. And now look here.
Yeah. So that region then. Let me just. There is that region, and that would be the aortic valve.
That's correct.
Which is distorted and irregular, and there is some dark brown discoloration at the level of the junction of the valve with the wall. So for that picture, my main differential will be erosive endocarditis of the aortic valve. I cannot see a nodular.
I'm sorry. That's the main focus. Good.
Yeah.
Okay, this portion is not clear. Is not clear. Is a residual aortic flap.
Okay.
And look here.
That could be a potential subaortic stenosis at the level of the base of the septum.
Good, Joao. That's the main focus. Complement is not easy, but if you try to put together the anatomical structure, if you understand the anatomical point, it's possible. It's not easy in this case. I agree with you. Because
yeah, I think I didn't recognize the outflow tract, to be honest. So maybe because the valve is distorted, I didn't recognize that it was a valve. I thought, in fact, it was the wall of the. I really thought it was the wall of the left atrium. I didn't realize it was the aortic flow, the left ventricular outflow tract.
Yeah, of course.
Sorry, can you show again all the structure on the left heart?
Fabio, I'm sorry, I don't listen you very well. I'm sorry.
Can you show again with the laser the structure? So you say the subaortic stenosis on the ventral aspect, and then going up.
There is a residual aortic leaflet here because there is a severe erosion of the valve. Of course, there is, Joao, which part also of the valve is involved here? Do you remember yesterday
when you say the valve itself or the valve apparatus, you mean, right? So if the valve.
Okay,
do you remember? You mean which cusp? You mean on this picture?
No. The cusp is not necessary in this case. But if you remember, yesterday we spoke about the anatomical structure of the aortic root, and we demonstrate some anatomical particular.
Yes. So if the valve is residual, and I can, if the little thin flap belongs to the valve, then that probably will be the area that is more affected in that region. Would be the valve and the sinotubular junction or sinotubular region. Is that correct?
Yeah. But because there is a link with the other picture. I mean, if you imagine the origin of the aorta, we say also there is a bulb. There is a mild dilatation. Why there is a mild, and it's normal, dilatation of the origin of the aorta?
Because we have, so there is in that area just after the valve, we have a mild dilatation. Is where we have also the entry of the coronaries, the coronary ostiums as well.
Yeah, and in the valsalva sinus.
Yes.
And that's the involvement of valsalva sinus with the involvement of the coronary ostium.
Okay. Yeah.
Okay.
It makes sense. It makes sense.
Yeah. And of course, here there is not, but in this case there was also an infarct of the myocardium.
Can we see it on the picture?
No, there is not in this picture.
Okay.
No, but in this heart.
Okay.
So why I put this picture of the kidney and the picture of the trachea?
I believe that is to show the consequences of the process that was happening in the heart, and also to support the diagnosis. So on the kidney, we can see that there is a discoloration on the left region, a brownish, really dark discoloration on the left side of the kidney, which to me is consistent with possible hemorrhage there, or an infarct, hemorrhagic infarct, and that would support the diagnosis of endocarditis with the embolism, and It could be also for other reasons. It could be also because of coagulopathy secondary to endocarditis. Then on the right we have a cross section of the trachea with some fluid and foamy whitish content in it, which I assume that the main differential will be either cardiogenic edema, or it could be also hematogenous pneumonia.
Yeah. I think I agree completely with you. In case of the kidney, you may to use also necrotic hemorrhagic area.
Okay.
Not only hemorrhage. That's very characteristic in the kidney when there is an infarct to see a triangle with the apex in the medulla. That's very typical. And of course, I agree with the pulmonary edema, because there is a severe damage of the aortic valve. Okay, compliment.
Massimiliano,
yes.
Just a question. So here we said erosive. Can we say ulcerative as well, or is that different? I just don't have this concept very clear in my mind.
Yeah, in this picture is more clear. In this point we have better the proliferative lesion here, but in general here is better visible the erosive. So in general we may to say in this case proliferative, but also ulcerative. So there are both in this case. Maybe here is much better the proliferative. What do you think, Jonathan? Maybe I will show you some picture again.
It's just like I don't know how to differentiate something erosive or ulcerative. For me, it's kind of a little bit similar.
Yeah, but erosive and ulcerative are synonymous.
Are they interchangeable? Because sometimes we say erosive, sometimes we say ulcerative, and we as opposed to vegetative lesion. So here, of course, it's not vegetative, but I agree there is this necrotic tissue. But it's just for me, I don't know if I have to use the keyword erosive or ulcerative. But if it's the same, I guess we can say both.
I mean, I remember also both the definition, ulcerative and erosive. The meaning is the same for me. Other question, guys?
Thank you.
Thank you.
Okay, another one.
I just want to check if my mic is working now.
Sure.
It does.
Can you hear me?
Perfect, Claudia.
Thank you very much.
We won.
Okay, Claudia. Ciao. How are you?
Oh, I'm fine. I'm very happy to be here today. Very sad because of yesterday.
Don't worry.
Yeah.
Do you want to try just for
Yeah.
the welcome picture?
Mm-hmm. So I think there's dilation of the right ventricle.
Okay, describe the anatomical. Sorry, Claudia. Describe the anatomical point of view, because remember,
we see a longitudinal cut through the left and right ventricle. We can also see the tricuspid valve and the right atrium with a little bit of the right appendage. And we can see the left ventricular outflow tract with the aortic valve. And the left ventricle seems to be concentric hypertrophied for a dog. And there seems to be a subvalvular narrowing from the ventricles or from a muscular structure underneath the aortic valve.
Not.
Okay.
So, take care, because if you look carefully, the left ventricle is not a real longitudinal cut section, because it's a more asymmetric section in the left ventricle. And for example, it's not so balanced section because we don't see very well the papillary muscle, for example.
Yeah.
So the cut section for the left ventricle is not so perfect in the middle of the cavity. And I don't see something too wrong in the left.
On the left side.
No, that's normal.
Okay, so it's just because of the cut. Yeah. Then on the right side,
okay,
we can
look at the right side.
Yeah, we can see the tricuspid valve, and it seems to be connected directly to the papillary muscle. Yeah. So we don't see the chordae tendineae well. So it looks like a dysplastic valve.
Yeah.
And the left ventricle, the right ventricle, seems to be eccentric dilated, which could be due to a volume overload.
Sure. That's the focus. So that's a tricuspid dysplasia. So, Claudia, do you know this kind of anatomical structure?
Yeah. It's moderator band.
Yeah, that's the trabecula septomarginalis.
Mm-hmm.
The right septomarginalis trabecula. That's normal. That's normal.
Mm-hmm.
Sometimes here we have a very strong muscular band with hypertrophy, and that's a very interesting malformation because it can induce a double right ventricle chamber.
Mm-hmm.
That's it. Here it's the point between the parietal wall of the right ventricle and the papillary muscle, and of course the septum. There is a transversal band.
Mm-hmm.
That's normal. The septomarginalis trabecula, and of course there is a problem in the junction between the leaflet and the papillary muscle. Okay, good. Other question? Everything is clear? Claudia?
Yeah, it's clear. Thank you.
Thank you. Another one.
Hi, good morning. I'm Maria.
Maria, I don't listen you very well.
Try to speak aloud, Maria, please.
Yes, I think I have some issues with the. Can you hear me now? Hi.
Maria, I'm sorry.
Yeah.
No, I don't listen, Maria, please.
Okay, I will solve Massimiliano.
Okay, thank you, Alessia. Thank you.
No problem.
Anybody?
Hi, can you hear me?
Sure.
Hi, this is Sid. I'm sorry I couldn't get involved yesterday. I was at work. So this looks like a terminal aortic trifurcation.
Sure.
And there appears to be and I'm guessing it's a thromboembolism in the at the distal aorta.
Sure, that's the condition, but please try to describe the anatomical situation.
Oh, I see. Okay. Do you mean that there is a dilation of the vessel before the clot, and then the clot itself, or?
So we are looking for the cavity of the distal portion of the aorta, just before the branching of the iliac and the sacral median artery. Is it correct?
Yes. Yeah. Yeah. Sorry, Massimo. I'm not sure what specifically how to describe it.
Okay. What about the anatomical description again? What do we see inside the artery?
So the arterial walls themselves appear smooth and regular, and then we have this. There's no scale, but we have this bright red lesion, which is the thrombus. The vessel.
I'm sorry. Are you sure that we made to say thrombus in this case?
Sorry. No, there is a sort of round rectangular lesion that looks to be obstructing flow in this area.
Yeah, but which is the name of this kind of finding? It's not a thrombus.
Embolus, you mean?
Say again?
As in embolism.
Embolism.
Yeah.
That's an embolus.
Yeah.
Take care about the definition of thrombus and embolus.
Yeah,
Of course, there is a link, because a embolus before was a thrombus in this case. Do you understand me?
Yes, no, you're right, because it's not the site of origin.
Yeah. Okay, what about the predisposing factor? Factor, not factor. Factor.
In cats, the most common cause is primary cardiac disease, usually HCM, but also restrictive cardiomyopathy or some other cardiomyopathy. It could also be non-cardiac in origin, so neoplastic is the main one, but really in cats, nearly always primary cardiac disease.
Yeah, it's the main link between thromboembolism and cardiomyopathy in cat, but also we know that in case of hypertrophic cardiomyopathy, the thromboembolic abnormality is more or less in 10-12% of cases, not so a lot of cases.
I'm sorry, I didn't quite hear that.
Not all the cat with hypertrophic cardiomyopathy have the thromboembolism, of course.
Sure, no, I agree.
More or less 10%, a little more.
But the most common cause of thromboembolism in the cat is cardiac disease.
Yeah. About the thrombus, you have to think about Virchow triangle. Do you remember in general part the Virchow triangle for the thrombus? The damage of, do you remember? It could be in general the thrombus formation because there is a damage of the endothelial or endocardial layer. It could be because there is some kind of thrombophilia, and could be because there is a blood stasis. Maybe
blood stasis, right? Yeah.
Maybe two of the three factors who can induce the thrombus in general.
Yeah, and so
which is the consequence? Which are the consequence of the aortic and thromboembolism in cat?
Clinically or
anatomically, and so clinically, but before anatomically, which is the consequence?
So you have this obstruction to blood flow, partly caused by the actual physical embolus, but also by, I forget which peptides, but you have reactive substances that cause vasoconstriction and worsening the blood flow distal to the lesion. You then have loss of motor function, most commonly in the pelvic limbs, cyanosis, lack of a palpable pulse, and then also over more time you can have tissue necrosis and reperfusion injury.
Yeah, but from a pathological point of view, we have hypoxia and ischemia.
Okay, yeah, sure.
Yeah, and then every functional disorder, neurological, muscular, the pain, such and such. Okay, any other question? Everything is clear? I think that it's for examination. You see this kind of vessel with something to wrong inside the cavities. I think it's not difficult to recognize also for anatomical point of view. So, but in this case, we see the embolism, not a thrombus.
Yes.
Okay. Oh, it's my recent case. Who want to try? I don't know.
I try, or
Sure. Who speak?
Claudia.
Claudia. Okay. Do you like the cat?
Maybe. So we see a longitudinal cut through the left and right ventricle. We can also see the right ventricular inflow tract with the tricuspid valve and the right atrium. And we can see the left ventricular outflow tract with the aortic valve and the aorta.
Yeah.
And at the apex of the left ventricle, we can see a very thinned area, which seems to be translucent.
That's correct.
And I'm not sure if there's a bit of whitish discoloration at the left ventricular side of the septum and also of the left ventricular free wall.
Yeah, there are some artifact because of the postmortem.
Okay.
Yeah, because the colleague frozen the heart, the cat, and so there was an artifact because of the frozen, and then also for the blood inside. It was a not easy situation for the preservation of the shape, color, and such and such. But I think it's very clear.
We have an aneurysma at the apex of the left ventricle, and it could be associated with ischemia in this area after loss of the blood flow associated with hypertrophic or restrictive cardiomyopathy.
Yeah, that's what we think. That's what we say. I have not a lot of experience about aneurysm of the apical of the left ventricle. Actually, all the portion now is fibrous tissue. There is not myocardium here. Just a connective tissue, just fibrotic tissues. And of course, we think about cardiomyopathy because hypertrophic cardiomyopathy or also other restricted cardiomyopathy because can induce ischemia because we know, for example, that in case of hypertrophic cardiomyopathy, there are important remodeling of the wall of the small medium artery. But in this case, also at the gross examination, but also with the histological examination, there are not finding of hypertrophic cardiomyopathy. You see, the wall of the left ventricle is not thickened.
Yeah.
Yeah, and so I don't know which is the cause of this aneurysm, because I don't see histologically alteration of the hypertrophic cardiomyopathy. I check looking also for the artery in the interventricular septum, in the circumflex artery, but everything's look normal. Also in the middle of the wall, there is not abnormal remodeling of the artery. Just very close to the connective tissues, but in this case, the remodeling of the vessel wall could be secondary to the aneurysm, not the origin. And so I'm not sure about the origin of this lesion, but morphologically speaking, it's very clear. Do you have experience about this kind of finding? Anybody?
Very rare. Like I think we have seen 2 cats with a very thin area.
Yeah.
But we didn't get a necropsy afterwards, so it was just suspicion from echo.
Yeah. Okay. We need post-mortem investigation, of course.
Yeah, we do.
Yeah, we need post-mortem investigation, and we need also for better understanding the disease to discuss together, pathologist and cardiologist.
Yeah, but in Germany, it's sometimes hard to get the owners to perform a pathologic examination. We always try to, but it's not easy.
Yes, okay, also in Italy, I think also everywhere, but also in human. But for animal, we have to do a cosmetic autopsy.
Yeah.
For small animals. To do the cosmetic autopsy. Yeah, to do a cosmetic autopsy, and so to show again the body of the owner.
Because that would be helpful.
Yeah. I think it's the main situation to follow, Claudia, because the owner have to see again the body of the cat, of the dog, and also in a right room, in a quiet room, not of course not in postmortem room or not in the hospital, but in a right situation. We need in veterinary medicine to improve in general the post-mortem activity.
Yeah, I think so.
Because at the moment, the post-mortem is put in the bag the body, and then put the bag in the frozen. Stop. So we have to think a lot about all the post-mortem situation of the small animal, and inside this situation there is the autopsy. We have to think about.
Yeah, it's so important for learning.
Yeah, sure, but for students, for us, for every people.
Yeah.
Okay.
Massimiliano, just a question regarding this yellowish discoloration. So this is almost just the epicardium that we can see. There is almost like no muscle left, no?
Here?
Yeah.
No, that's all the wall. There is not epi, neo, and endocardium. There is only a fibrotic wall.
Yeah, but this is basically if you look at the white line, the outer white line of the heart, just which is obviously the epicardium. It's look like a continuum. And then when I look from very close, obviously I cannot see any muscular wall.
But you think about the aneurysm?
Yeah.
Okay. Yeah, there is some whitish and more yellowish part, but everything is fibrotic tissues. Maybe there is some portion also of epicardial fat. Yeah, but maybe very thin layer.
Yeah, so there is no muscle anymore. That's what I wanted to point out.
No. That's clear because look at the transillumination. There is not muscle.
Yeah. Thank you.
Yeah. Okay, Guy. Do you need a break? 10 minutes.
No.
Who want to break? Who want to drink a coffee, a tea? Move your leg.
If everyone else wants to.
Say again?
I said, to me, everything is okay. If everyone wants to, I'm more than happy to make a coffee. I'm always happy to make a coffee.
Who want a coffee? Okay, Guy, I need a coffee. I'm sorry. I need a stop.
So, Massimiliano, when we should meet again?
Yeah.
In 10 minutes or?
10 minutes. 10 minutes.
Okay. Okay.
Thank you. See you.
Okay. Thank you. Thank you.
See you in a second.
Today, I think, is a great opportunity to bring together human cardiologists and veterinary cardiologists, all focusing on new ways to help both dogs, animals, and our patients to have better outcomes in heart failure, especially focusing on new ways of decongesting, knowing about congestion, detecting it, and new diuretics.
To me, it's the first example where I actually see the use of PK/PD modeling techniques influencing so much the dose selection. From that perspective, it's kind of a breakthrough, and the way that we are trying to use data in preclinical staging to support dose selection.
I do think new data on diuretics will give us a step forward in veterinary medicine. Understanding the pharmacokinetics and dynamics in the normal animal will help us predict what to expect in the sick animal, and it's really nice to know the basic information in the healthy dog.
The important points, I think, are the really extensive studies that have been done on the pharmacokinetics, pharmacodynamics of torsemide, and the opportunity we have to apply a new diuretic to our therapies. And importantly in that, this is a longer-acting diuretic and looks to have great advantages over previously used diuretics, such as Lasix. And it's exciting that this is going to be available.
I think there's a lot of take-home points that we can share with other cardiologists, general practitioners, and our veterinary students to help us really inform the use of the proper diuretic and the best diuretic in our patients with heart disease. And I think there's a lot of data that was presented here that really does suggest that torsemide is a better diuretic that produces a better profile and potentially a better response related to mortality and morbidity in patients with heart failure.
I think for the first time now we have a choice for a diuretic in animals that have heart failure for the first time due to degenerative mitral valve disease. I think that's a unique aspect and something that is clinically needed.
I'm pretty convinced now that we should move on a bit. After this meeting, I feel more comfortable to use torsemide on a single dose per day, and obviously we really need to monitor, electrolytes and creatinine, but I think that in the future more and more people will use torsemide more than furosemide.
What we learn with the studies on torsemide is about its effectiveness in comparison to furosemide, its effectiveness as a once-a-day medication, which can be very convenient for many owners, and the relative risks and benefits by comparison to furosemide, which is a very familiar drug to most cardiologists. So I think there's a lot of value out of these studies.
Massimiliano, are you there?
Eccoci qua. Here we are.
Please share again your screen.
Here we are. Chris?
In the meantime, Massimiliano, sorry if I can catch the opportunity, say to the colleagues, I don't know if they are in contact with their SEVA representatives in their countries, but in case if you need some information, please ask me, because we have new findings as the best study introduced by Clark Atkins and the publication of Carpodium study for Isamid introduced by Marco Yama. So if you want to see the presentation or get some information, I can keep you in contact with the SEVA representative of your countries. Thank you, Massimiliano.
When is the best study meant to be published?
The best study, do you mean?
Yeah, when is it going to be published?
I think in the second quarter of the year, so maybe we expect for April or May, if we are lucky.
I didn't get it because my connection is very unstable. Can you repeat, please?
Okay, I think in April or May, if we will be lucky.
Okay, thank you.
You're welcome.
So we may to continue.
Emiliano, we don't see your screen.
Oh, sorry, maybe I.
No problem.
Now?
Perfect.
Good. Thank you, Alessia. Okay, we need to continue. We want to try description, morphological diagnosis.
I can have a go.
Sure, Ursula.
Okay, then on the left side, we have a gross pathology of a cross-section of the heart of a cat. What we can see, it's the cross-section through the left ventricle and the wall of the right ventricle as well on the left side of the image. Septum, interventricular septum and the free wall of the left ventricle are definitely hypertrophed or thickened. The septum more than the free wall, in my opinion. But the whole myocardium of the left ventricle is like thickened and irregular. Additionally, we can see this whitish endocardial and probably subendocardial layer along the interventricular septum. That's for me consistent probably with some fibrotic degeneration, maybe some fibrotic extended fibrotic lesion in the endocardium and then subendocardial region.
Yeah, that's correct.
I don't know if I'm right or just it's like optical misleading, but in the cavity of the left ventricle, I can see some, yeah, that's exactly this place, yeah, some reddish particle.
Yeah,
that could be coloration, but maybe
no, that's blood clot. That's I'm sorry.
Okay.
Yeah.
In the upper part of the image, we see left atrium, or the more exactly left atrial appendage, that it's severely enlarged, in my opinion.
I agree with you, Ursula.
The free wall of the right ventricle is more or less normal.
Yeah. So.
And yeah, on the right side, we have the histopathology of the same cross-section, or very similar to this. And what we can see, that is really severe fibrotic lesion in the endocardium and subendocardial area of the left ventricle. And there is some on the in the free wall on the right side of the image. There is some reddish color as well. It's probably replacement fibrosis.
Yes. Yeah. Everything is correct, Ursula. Everything is it's fine. So on the right, the histological picture, just to improve the information, the stain is for collagen, in particular for collagen. That's the name is Picrosirius red. But anyway, it's correct. But look also between the
I wanted to continue, because there is this fibrosis connecting the free wall, or that's probably a papillary muscle, with the septum. That is like a bridging lesion, and that is very very characteristic for a kind of or type of restrictive cardiomyopathy.
Yeah,
it's connected with this endocardial and subendocardial fibrosis.
Yes, I agree with you. From a pathological point of view, the name could be also endocardial fibrosis, endomyocardial fibrosis.
Okay, that's better.
From an anatomical point of view. From a functional point of view, is restrictive cardiomyopathy. But also in pathology, we use restrictive cardiomyopathy.
Okay, that just for my information, is better to say it's endomyocardial fibrosis or subendomyocardial fibrosis.
I prefer endomyocardial.
Okay, thank you.
Submyocardial. Yeah, I think it's a clear endomyocardial fibrosis. Or subendocardial mean that there is not endocardial involvement.
Okay, that's correct.
So, any question? Everything is clear for other colleagues? Okay, another one. Who want to try? It's not easy. I know.
Maximilian, if I can ever go if no one wants to try.
Sure.
So we are looking at the dorsal, from the dorsal aspect of.
Sorry. Just try to understand where we are.
So I think from from we are looking at a dorsal view of what I think is the left atrium.
That's correct. And if you say left atrium, dorsal, but also dorsal and caudal.
Dorsal and caudal, yes.
Do you agree?
Because we have, yes, with the left and the left auricular appendage is pointing cranial as well.
Yeah. Is it clear for everybody? Because I'm looking at septum, of course, that's the atrioventricular valve, of course. And so that's an auricle. So I'm looking for an atrium in general. And if in front of me, there is the septum, and in my left, there is the auricle. That's because I'm in the caudal point, dorsocaudal point of view. Okay, Joao.
Yeah. So, so in terms of abnormalities, I can see that the mitral valve has a nodular thickening, mainly on the septal leaflet, and I can see that I think one of the chordae is ruptured, at least, because is basically prolapsing into the right atrium, so it needs to be ruptured. In terms of discoloration of the mitral valve, I cannot see any major discoloration, so I don't think this lesion represents a vegetation. I think it's just a degenerative process in the mitral valve. I think also on the caudal aspect, caudal medial aspect of the left atrial wall, I can see that there is a irregular thickening of the wall, of the surface of the wall, which I think is consistent with a jet lesion. I can see a communication, which I'm not sure if is if is the entry of one of the pulmonary veins, or is it in fact a defect in the interatrial septum.
I'm sorry, Joao. Here?
Yeah. No,
Here?
just there. So I don't know if this is a entry of one of the pulmonary veins, or if it's a defect in the interatrial septum. I am not sure.
Look here, where we are.
That would be the interatrial septum.
Sure, and that's.
So that would be a defect in the atrioventricular septal defect in the.
Yeah. That's correct. So one more.
Can I just something?
Yeah.
I'd just like to ask, the pulmonary veins, they all go into the left atrium caudally, right?
Caudally, but not only caudally. So the left one is more caudal and left. The right is in the right side.
Okay, so that area, or where do we have the AST, that would not be never a region where the pulmonary vein would go in, right? Would that be more caudal than that?
Of course, and also because that's the septum.
Yeah.
It's not. Okay. It's not the wall. That's the septum.
Yeah.
So summarizing. Joao, I'm sorry. Summarizing. The first abnormality.
So a nodular thickening of the mitral valve with rupture of the cord.
I'm sorry. I'm sorry, Joao. The name of this disorder is easy.
Oh, a degenerative mitral valve disease.
Wonderful. The second abnormality.
Atrial septal defect.
Sure. So, number 3.
So I also said the jet lesions, but are most likely related with the mitral regurgitation jet. And I think it seems, although I'm not sure, it seems that the left atrium is also dilated. So is there any other abnormality that I have missed?
Okay, we have to repeat. Number 1.
Mitral valve, degenerative mitral valve disease, atrial septal defect.
Okay.
Jet lesions.
Sure.
left atrium enlargement, dilation,
Sure.
rupture of the chordae tendinae.
Sure. The last? It's related to the rupture.
And prolapse.
Prolapse.
Yeah.
Good. Prolapse of the septal leaflet. All together. Yeah. Thank you. Everything is clear. That's normal. That's normal because that's the coronary sulcus. That's normal.
Okay.
The left coronary sulcus. Any question? And why there is this kind of arterial defect?
So that could be because of it could be a congenital defect. It could be a malformation.
Yes, but I'm sorry. In this case, why? It could be it could be congenital. I agree with you, but in the beginning of the clinical investigation, there was not.
Okay. So that would be a most likely a left to right shunt through the that would be through the foramen ovale.
Yeah, but why?
Because of increased pressures in the left atrium. That would open the yeah, exactly.
Yeah. Sometimes we see also another kind of rupture. In this dog with a severe myxomatosis degeneration, with a severe left atrial enlargement, is not very common the interatrial defect, and of course usually is in the membranous portion of the septum. But sometimes we see also another kind of rupture in another point of the atrium.
You mean another defect in other areas of the atrium because of dilation of the left atrium? That's what you ask. Sorry.
Yeah. Maybe the rupture, because in this case it's a rupture. It's not a defect, but maybe the rupture because the dilatation is not in the septum, but is in the parietal wall.
Oh, you mean the rupture of the left atrium?
Sure. In general, could be or in the septum or in the parietal wall.
In the wall.
Yeah. In the last case, what do we see? Which is?
We would see as well hemorrhagic pericardial effusion when we open the chest. Probably we see a globoid pericardial sac with most likely hemorrhagic effusion there.
Yeah, hemopericardium. That's correct.
Hemopericardium.
Yeah. Other question? Everything is clear? That's a severe myxomatosis degeneration in dog with different consequences. Who want to try?
I can give it a try.
Good, Mattia.
Mattia, yes. Okay. So I'm gonna zoom in a tiny bit. Okay, so we do have an histological section of what. No, it doesn't allow me. Okay, of what it looked like a myocardium. On the left, we've got the myocardiocyte in a cross-sectional cut, and on the central part, we do have instead a layer of longitudinal fibers that they've got a different appearance. They are probably of different origin and probably not myocardiocytes. And then we've got a final layer more towards the right of eosinophilic cells that they might be the endothelium, I think. Okay.
Yeah,
So,
sorry. Just for, okay. Here I put empty space because that's the cavity.
yes.
And that's correct, that's the endocardium.
Yeah.
Because if I want to put epicardium,
Yeah.
usually there is fat, some adipocytes.
Yeah.
Usually we see very well coronary vessel.
Yes.
But when we want to put the endomyocardial component, we have to do something like that. Also some empty space, because here we want to say take care because there is a cavity.
Yes. Okay. So as I said, I mean, I will probably, the part on the right of the image reflects a tiny bit the same structure that we've got on the left, obviously. Although there are some differences, and I cannot fully appreciate the shape of the right side structure, but I would say that it might be either the other side or a papillary muscle on the right side. I will focus a bit more on the left side of the picture now. So the myocardiocytes, they look from what, I mean, it's difficult to appreciate them from this magnification, but I would say they look appropriate in number. There's no obvious area of rarefaction of the myocardiocytes, nor of obvious, let's say, fibrotic process rather than fat or fibrosis infiltration. There are a number of cells that they look like just the nuclei. I think those are just the nuclei and the nuclei of the myocardiocytes that we can appreciate as a more basophilic structures.
Yeah, but yeah, I'm sorry. In this type of power field, you see just a little of the nucleus. Of course, there are basophilic and so purple point, but not more.
Yeah, yeah. Indeed, I was trying to get into the screen on my computer, but
sure, maybe. Or to use the microscope in front of
the myocardium side.
Yeah, maybe with a microscope in front of the monitor could be also an idea. We are kidding, of course.
Okay, so I think that from the myocardial side, it's so far to me largely, well, to me it's actually rather unremarkable. You will probably tell me if it's not. And then we've got towards the right side of that structure, we do have the endocardium. That is instead more, let's say, with the presence of more wavy fibers. Probably that's some collagen too, but not much. It's not like too much. And then we've got an endocardial, an endothelial cell layer, I think, on the very, very inner surface. So you probably you're probably asking what's the diagnosis of this dog? So or cat, but I don't really have a diagnosis for these. I think to me it looked relatively unremarkable. Maybe there's a thickening of the endocardium. That would be my only thing.
That's the diagnosis. And that's because spindle cells, of course, with hematoxylin, eosin, stain, it's the basic presentation. But I mean, I think it's a clear the thickening of the line, because take care, because epicardium and endocardium are just aligned. If you see something more thickening about the line, there is a strong situation, there is a problem. Okay. And that's because there is endocardial fibrosis.
Perfect, okay.
But you made a good diagnosis, and You have made a good histological description. Compliment. It's not easy. Okay.
Can I ask you something?
Sure.
On the bottom of the picture, sorry, on the previous one.
Yeah.
Fantastic. On the previous one, yeah. On the bottom, there is an area of a slightly different morphology of cells. On endocardial, no. Bottom right.
Here.
More lower down. Lower. Yeah. Yes, over there. Yes, yeah. Those ones. Is it just a different cut section or?
Yeah, I think so. It depends on the cut of the histological section, because I don't see nothing of significant. Just
perfect.
Maybe a little more thickening, but it's not so clear.
And my last question is at 10 o'clock, there is a structure, like a tubular structure, more towards the middle of the picture.
10 o'clock. Here?
Yeah, so right, yeah, so right.
Right, here?
The right. Another, no, the one more to the right. Yeah, that one. And inside that, there are those kind of cells, I guess. And initially I thought they could have been like, I don't know, white blood cells or some stuff of.
Yeah. But, that's a vessel. That's a vessel.
Yeah.
Of course, you don't see the red blood, but not always you see in histological section the red blood. But of course, that's the structure of a vessel. I think it's a vein.
Okay. And those are just cells like blood cells. Okay.
Yeah. And at the histological examination, we have some possibility to see the morphology of a vessel. We may to see a perfect transversal section like a ring. We may to see more oblique orientation of the cut section or a longitudinal cut section. So it depends from the histological section.
Perfect.
Okay.
Thank you very much.
Yeah. Other question? Everything is clear?
Massimiliano, can I ask you a question?
Sure,
when we describe the endocardial layer, we can just say they are spindle cells. We cannot say the type of spindle cells. We cannot say whether they are vascular endothelial cells, or we cannot say if they are fibroblasts. We can just say the shape of the cell, isn't it? The spindle cell, and we shouldn't define more than that, isn't it?
Yeah, that's correct, Joao. It's not possible because of the power field. If you look carefully, it's more or less clear that the shape is elongated.
Yeah,
but not more, please, not more.
Okay, perfect. Thank you.
Thank you.
Shall I try? It's Claudia.
Claudia, sure.
Okay. So it's a histology picture, and I think the structure that we see is an AV valve.
Yes.
And in the upper part, we can appreciate the layering. We have an atrialis, spongiosa, fibrosa, and ventricularis. And in the lower, in the lower part, we have a marked thickening of the valve.